So hello everyone and welcome to our first session in the Tackling Liver Cancer Disparities webinar series. Um, we are partnered with Health Council of South Florida and South Florida Cancer Control Collaborative. Our topic today is on liver health basics, which will cover liver anatomy and function in disease and prevention. My name is Marissa and I'm the engagement coordinator with the lovely GLI engagement team. And here we also have Vicki, who I will pass it over for her to introduce herself.
Hi, everyone. So my name is Vicky Perez Marrero. I'm the regional coordinator and a community health specialist at the Health Council of South Florida. So a little bit about the Health Council of South Florida. It's a trusted regional organization dedicated to improving health and wellness in Miami-Dade and Monroe counties down here in South Florida. For over 50 years, HCSF has provided unbiased health data, strategic planning, and community service while fostering collaboration and advocating for equitable healthcare policies. And then the Southeast Florida Cancer Control Collaborative, also known as the SFCCC, is a voluntary network of healthcare providers, community organizations, and advocates working together to reduce the burden of cancer across Southeast Florida. It's supported administratively by the Health Council of South Florida, and it promotes education, advocacy, and research to improve access to cancer care in the region. So thank you, Marissa, and thank you, Dr. Box, for having us.
Very welcome.
Great, thank you. So, and with that, thank you so much for everyone joining us here today. And I'll go ahead and give a quick introduction to our speaker. So, Dr. Terry Box is the founder of the Hepatology Educators based in Salt Lake City, Utah. He created the organization shortly after his retirement in July 2024 from the Spencer Fox Eccles School of Medicine. At the time of his retirement, Dr. Box was an associate clinical professor of medicine, medical director of Project ECHO, and assistant dean for community faculty at the Spencer Fox Eccles School of Medicine at the University of Utah. He had joined the faculty of School of Medicine in 2009 after a lengthy tenure in hepatology and liver transplantation at the LDS Hospital in Salt Lake City from 1983 to 2009. During his 4 decades long career, he has been actively involved in clinical research in the areas of chronic viral hepatitis B and C, as well as transplant hepatology. Dr. Box has a unique perspective of caring for liver transplant recipients, having himself been the recipient of a life-saving transplant in 2002. In 2009 and 2011, he and his teammates on Team Donate Life participated in the bicycle race across America to raise awareness of the need for organ donation. During the last 6 years, he has focused primarily on working with state agencies and community partners in Utah and the Mountain West to enhance screening for and linkage to care for patients with chronic HCV in the hopes of achieving micro-elimination of HCV in that part of the country, a commitment he continues through his platforms as a community educator. Thank you so much, Dr. Box, for being with us here today, and I'll pass it over to you for the presentation.
Well, thank you very much. It's indeed a pleasure to be here today and talk about some basics of the liver relative to its anatomy and its function, and why I think you'll agree with me it's an extraordinarily important organ once we get to know a little bit more about it. And obviously in this setting, learning about hepatocellular carcinoma, liver cancer, it's very important to know, I think, from where all this begins. So in the process today, as you see, we have about 4 objectives. We're going to start with a high-level overview of the anatomy of the liver, both from its external perspective and a little bit from its internal perspective, and then move from that to a discussion, a brief discussion of the liver function in health. And amazingly, this liver does over 500 different things. So I promise you we won't talk about every one of them, but I think you'll have an appreciation for it once we have our discussion. And then we move from the liver and health to signs and symptoms of liver disease, and then briefly discuss how the liver moves through the stages of illness once it has become chronically diseased. So here are 2 artist renditions, sort of a very high level rendition of the external as well as the internal anatomy of the liver. And as you see on the left-hand side of the slide is the external liver. And this liver is appropriately colored here. It's a sort of a reddish brown organ. You can think of what you see in the grocery store if you look at a calf's liver. Our liver is more or less the same color and the same shape. As you see, it's a bit of a wedge-shaped organ here with a domed surface. And this domed surface really pertains to where it lies in our body. In addition to the liver, which is a very large organ, actually the second largest organ in the body, the largest organ in the abdominal cavity, we have an organ that is really tucked up underneath our right rib cage. And this organ, as big as it is, about 3 to 4 pounds in health, it's hard to feel, even though it's a big organ, because it's really high up in your rib cage. If you feel at the bottom of your rib cage on the right side, it's really almost impossible to feel. In fact, if you feel your liver, maybe it's big. Maybe we need to talk more about it. But nonetheless, that's where it lives. And the diaphragm, which separates the chest cavity above the abdomen from the abdominal cavity, is sort of a dome-shaped muscle, which makes the liver conform to its shape where it is. Now, the liver doesn't flop around inside your abdominal cavity. It's held in place by a couple of ligaments you see here, noted as the falciform ligament and the teres ligament, which really divide it into 2 lobes. It goes across the midline of your body, by the way. It's mostly in the right upper abdomen, but it does cross the midline. And the part of the liver on the left side is called the left lobe, and that larger part on the right is the right lobe. And that matters somewhat when the liver is operated on. The surgeons need to know where they are. They need to appreciate that. But quite frankly, they are fully integrated. You can't see a division between them. Now, just to get a little bit more technical, the liver is grossly divided into lobes, but there are literally thousands of tiny little lobules in the liver where all the metabolic business takes place. And these are somewhat honeycomb-shaped collections of hundreds or thousands of little microscopic liver cells where the business end occurs. Now, you see that this organ is served by 2 blood vessels bringing blood to the liver and 1 draining it back to the heart. The deep red aorta is a large tubular blood vessel coming directly from the heart, from the left side of the heart. It arches over the breathing tubes within the chest, goes through a hole in the diaphragm into the abdominal cavity, and as soon as it gets down to the level of the liver, it begins to send off branches, and the branches of this aorta are filled with arterial blood that is highly oxygenated. The oxygen comes from the blood's encounter with the lungs before it goes to the left heart and is pumped out. Oxygen is necessary for the function of every organ in our body, and the liver gets a full service from the aorta with sort of the first branch coming off to serve the liver. There is another input of very rich blood, as you see in this lighter blue, vessel called the hepatic portal vein. This vein is made up of blood veins coming from your small intestine, your stomach, and the spleen, which is on the left side of your abdomen. This blood, because it comes from the intestine, where you digest everything you put into your body, is rich in nutrients. These nutrients are the building blocks of everything that goes on in the liver, and the liver makes everything needed for almost every other organ system in your body. Now, you see, in addition to the arterial blood from the aorta and the intestinal blood from the portal vein, the gallbladder hanging on the undersurface of the liver here on the right side. The gallbladder actually receives bile from the liver, and the bile which the liver makes contains sort of the end results of all the work the liver does, sort of the byproducts of construction, things that need to be gotten rid of. They're no longer useful. They go out through bile into the gallbladder. The gallbladder squeezes them into the intestine, and it goes out through the colon with the feces. There are some components of bile, however, that are useful for digestion that the liver makes and sends into the gut with the rest of the bile. Now, once the liver does the many things that I've been mentioning, those proteins, those enzymes, those structures that have to go elsewhere are sent out of the liver on the backside into this large dark blue vein called the vena cava, supplied by the hepatic veins draining the liver into the vena cava. The vena cava blood then goes back to the right side of the heart and then out to the lungs, completing the circular nature of the heart and the circulation. So this, again, very high level understanding, I hope, of the anatomy of the liver from the outside. Now let's take a very sharp blade and just cut through the entire liver down the middle. And again, just a very high level view of the branches of these vessels. So as you see, the artery from the aorta begins to branch just like a tree branches. And these branches keep getting consecutively smaller as they become microscopic. And this is taking all that oxygen-rich blood to every part of the liver. By the way, the heart supplies the liver with a lot of blood. Almost 15% of your body's blood at any one moment is in your liver. So it is a critical organ from a number of perspectives, particularly how much blood it takes to run the factory, so to speak. Now, in addition to the branches of the arterial tree, from the portal vein, we see the same kind of branching, and they go side by side. They go together. And the biliary tree, the bile duct system within the liver that drains the finished, drains the byproducts of metabolism, branches with these vessels as well. And on a microscopic level, you see all three of these in every lobule. They're like three musketeers, they hang out. Now, after the liver has done all of its wonderful work, it has to send that out, and as it does so through the dark blue veins you see here, as I described earlier. Now, that is, again, a very high-level perspective of the internal anatomy. Let's move from here into a discussion, again, without going into gross detail of the 500 plus things the liver does, of sort of the broad function of the liver. And then I think you'll understand why it's such a critically important organ. First of all, as you know, everything we put into our digestive system gets broken down, starting in the stomach and finishing in the small intestine. And then fortunately, the digestion breaks everything down into small enough components that it can be absorbed through the lining of your intestine. There are 12 to 15 feet of small intestine in which the products of digestion occur. And they go through the wall of the bowel into the vessels that drain into the portal vein that take this nutrient-rich blood to the liver. Well, these products of small intestine digestion are not small enough. They're not basic enough for the building blocks that the liver has to work with. So it breaks down your protein into the final building block, the amino acids. It breaks down your sugars, your carbohydrates, into the smallest piece, the glucose. It breaks down your fats into carbohydrates and triglycerides, and even into smaller pieces of triglycerides called free fatty acids. These are the components of what we ingest that the liver uses to make thousands of proteins, to make enzymes used by other parts of the body, to take those proteins and those enzymes from the liver through the blood to where they belong. So the liver is constantly making products for its own benefit as well as for many other functions in our body. And it has this unique sort of love-hate relationship with fats. The liver stores some fat, but if we get too much, the liver gets sick. The liver likes triglycerides. It takes off a branch of a triglyceride called a free fatty acid and uses it for energy to run the liver. But if you get too many triglycerides, the body makes fat. Cholesterol is necessary for hundreds of things in your body, but in excess, it hurts the heart, it hurts the brain. So the liver is breaking down cholesterol or making cholesterol, breaking down triglycerides or making it. In the process of doing all of this, creating these proteins, these enzymes, the liver creates its own method of getting rid of it. And that's the bile that's created between the bile duct system and the liver that takes the residue from the metabolic processes, as well as things from cholesterol breakdown that are useful for digestion called bile acids. So it not only creates a lot of things for its own use to make all these wonderful things that run your brain, run your muscles, run your kidneys, run every organ in the body, but it also stores excess nutrients for future use. And that would be storing excess glucose as a very compact form of carbohydrate called glycogen in the liver. And it uses it for its own use, or more importantly, if your muscles are getting fatigued and there's not enough glucose for them to use, they call on the liver and it sends out glucose from its glycogen stores. It's a great resource for energy reservation. It also stores vitamins. There are certain vitamins that your liver loves to store. Vitamins A, D, K, E. They're stored in the liver. Minerals, iron, which is critical for making red blood cells. Copper, which is critical for other functions in the brain and in the kidneys, for instance, are stored in the liver until they're needed. In addition to all this good work in manufacturing and storage, the liver is also a detoxifying agent. It detoxifies many things we put in our body that could be harmful. Now, what is the most commonly ingested toxin that we have? I don't think you have to think about it very long, but it is alcohol. Alcohol is a toxin. There is no doubt about it. Fortunately, the liver can modify ingested ethanol by digesting it in two different pathways. One is the beneficial pathway, and the other pathway is what happens to alcohol when it's taken in excess and it creates bad byproducts. But the liver, if it's not overwhelmed by such a toxin, can detoxify it and keep it from permanently damaging the liver. The liver also modifies things that we ingest, such as medications. Many of our medications have to be changed in the body before they're useful at the other level where they're intended, like the lungs for a pneumonia, or like the kidneys for a kidney infection. The liver, by virtue of creating these metabolic complexes, will make those modifications. There are other toxins that the body makes that the liver can also detoxify. And your muscles are one of the biggest toxin producing organs in your body. Muscles are continually breaking down old muscle cells and replacing them with new and perhaps bigger muscle cells as we grow, or bigger muscle cells as we work out, or smaller muscle cells as we get sick and shrink. The breakdown product of muscle is ammonia. For those of you who are familiar with chronic liver disease and what it can do to yourself or your family or people that you've taken care of. When patients with advanced liver disease get very sick, they get confused, they get somnolent. They can even go into coma. That's because of excess ammonia that the liver's not able to detoxify in the state of chronic liver disease. But ammonia is changed to a substance called urea, which is then put back into the blood, and it goes out through your kidneys. So the liver and the kidneys take care of getting rid of ammonia. The liver also gets rid of things that are aging, that need to be gotten rid of in your body. And the main one is part of your hematologic system. It is red blood cells. Red blood cells, which carry all that necessary oxygen because of the hemoglobin, that's part of the red blood cell, they live for 90 to 120 days. During that 4th month of life, they begin to age. They get wrinkles, sort of like we do when we age. They begin to stick to one another inappropriately and in inappropriate places. The liver has a method to identify the shrinking, dehydrating, sticky red blood cells and send a specific type of cell to gobble them up called a phagocyte, which then breaks it down, takes the hemoglobin, which has been carrying the oxygen, breaks it down into bilirubin and iron, stores the iron, sends the bilirubin out in the bile to get rid of it. Just a minor function for the liver, but one that's critical for your health. The liver also filters out bacteria that escape through the gut wall into the blood, going back to the liver. And it does have an immune network that identifies those bacteria in small numbers and is able to take them out. So we have a modifier, detoxifier, filter that works wonderfully well. And finally, it creates blood clotting factors. It does another job for the hematologic system by creating factors that help our blood clot normally. There's no surgeon in the world, regardless of how much cautery or how many ties they can tie around a bleeding site, that can stop bleeding if we don't have adequate blood clotting factors. And the liver makes 9 out of the 13 clotting factors in the body. Lastly, and equally importantly, because the liver has so much blood flowing to it, 15%, almost 1/7 of your blood at any one time, as a chronically diseased liver begins to shrink because of scarring, it begins to grow nodules which interrupt blood flow. All that blood flowing to the liver has a hard time getting through the liver, and it decreases the amount of blood being returned to the heart, which decreases the amount of blood being sent to the body. And in advanced liver failure, that blood flow not getting to your kidneys can also harm them. So in 12 bullet points, I've given you a bit understanding, I hope, of what some of the many things the liver is doing for us in our health. And as we lose these functions in chronic disease, the liver begins to fail. So I am sure all of you are familiar with blood work that pertains to the liver. Even in health, we should be having all of our organs periodically assessed to make sure they're still healthy. All organs have unique blood tests. Some blood tests are shared between organs. And I've listed on this slide the main blood tests that are pertinent to assessment of the liver, both in health and disease. Now, the liver, as I've intimated, is made up of cells that are specific to liver function. And then the cells of the biliary tree are different, quite frankly, than the cells of the liver, but they live closely with one another. They integrate with one another. They share many functions, but they are separate. And hence their laboratory tests are separate. So from the hepatic perspective, the pure liver perspective, we have 3 tests that are pertinent to injury to the liver cells. So regardless of what is injuring our liver cells, what disease or toxic manifestation we may have, the markers that elevate as the cells are injured and begin to leak out their contents are ALT, AST, and LDH. Alanine aminotransferase, aspartate aminotransferase, and lactate dehydrogenase. The latter 2, the AST and the ALT, are shared by other organs like the heart and the muscles. The ALT is more or less unique to the liver. So when that goes up, we know we're dealing with liver injury. The liver makes albumin, that's the transport protein I was mentioning, makes millions, billions copies of albumin. When it gets sick and doesn't work well, albumin levels in our blood go down. The liver makes globulins for our immune system. It helps fight infection with the immune system by making globulins. When we get really sick, globulin production goes down when the liver gets quite dysfunctional. Now, pertinent to the bile duct system itself is a peculiar enzyme called alkaline phosphatase. It's not only there, it's also in bone, and it's actually also in the placenta. But most of the alkaline phosphatase in our blood comes from the liver. And when that goes up by itself, we know that the attack is not on the liver specifically, it's on the bile duct system. Also going up with biliary injury is the gamma GT, the gamma glutamyl transferase. It too shares other reasons to go up, such as excessive alcohol or use of opioids. Bilirubin is the byproduct of the breakdown of hemoglobin that I mentioned before. It goes out of the system. It's not a useful byproduct. It goes out of the system via the bile. If it can't get from the hepatocyte into the biliary tree, it goes up. It leaks out into the blood. If the biliary tree is blocked, the liver may be working well, but it can't get out of the body, and then it leaks back into the blood. Other labs you see on the right-hand side include the prothrombin time, which is one of those clotting factors. If you're not making enough prothrombin, that prothrombin time gets bigger. That means your liver is not working well. Prothrombin times across the world are different per lab. In order to make the meaning, a prothrombin time elevation meaningful, there's a neat little equation called the international normalized ratio that makes all PTs the same. Platelet count goes down when you have cirrhosis and high pressure in blood not getting through the liver. Platelets are gobbled up by the spleen, which is getting bigger because it sees all that backed up blood. I've already mentioned injury to the kidneys by virtue of poor blood flow out of the liver. Markers of kidney dysfunction are creatinine and BUN. They go up in advanced liver disease. That is a very bad situation. Now, liver fibrosis scores, with which you may also be familiar, and I hope so, they're becoming more and more familiar as we do fewer and fewer biopsies. They take either basic labs or specific labs, put results from the AST, ALT, platelet count, maybe the patient's age, into fairly difficult to interpret equations, but you do this online with a calculator, and you get a score. You get a FIB4 score. You get an APRI score. The score will be correlated with an estimation of the amount of fibrosis, of scar tissue in your liver. They're good. They're not perfect. They're not great. In order to make them great, a more recently approved test is called Advanced Liver Fibrosis Score that uses 3 components in the blood specifically related to fibrosis. But this is a very expensive test and one that we don't do very often unless we're having challenges figuring out our FIB4, our APRI, or how it may integrate with some of the liver imaging tests that we also use to learn about the liver. Now, as I mentioned, we're doing fewer and fewer liver biopsies, and that's good news for all of us. None of us hepatologists, none of the gastroenterologists you may know enjoy doing this or enjoy doing this. We're doing fewer and fewer, mostly now just to define cancer of the liver. We have, over the last 5 to 6 decades, been fortunate enough to have the development of ultrasound, which indirectly gives us a view of all the organs in our abdomen, specifically to the liver. We can see its shape, its size, whether or not it's nodular, whether or not blood flows through it normally, whether there are masses within the liver, or is the spleen big? Does the blood flow back to the spleen? It's fairly crude with ultrasound, but for years that's all we had. And then about 40 years ago, we got computed tomography. What is that? Well, it's really just basic x-rays, but it's thousands of them sort of stacked on top of one another to give us a much clearer image of the liver, of the pancreas, of the kidneys, of the intestines, in the chest, of anything in the chest. This has been around for a long time, with and without contrast. That's the way we define many hepatocellular cancers. Sometimes we need more help, and about 20 years ago, we got magnetic resonance imaging, using magnetic energy and the way that it interacts with certain tissues to get us even clearer images of what's going on inside our abdomen, what's going on inside our chest. We get better, clearer images, perhaps, of cancers, of where they may have metastasized. How big is the liver? How small is the liver? How nodular is the liver? And finally, in the last 10 years, we have been fortunate enough through the work of investigators across the world to use another method to determine how much fibrotic tissue, how much scar tissue is in the liver. Elastography is a measurement of stiffness. This measurement of stiffness is a surrogate for how much scar tissue is in the liver. Scar tissue starts out after you've had the same injury over and over again because of a disease or a toxin or an immune issue in the liver. Once you have chronic inflammation, you begin to put down scar tissue. Scar tissue at first is thin, flexible, can be done away with. After years, decades, you get thick bands of stiff, fibrous tissue replacing normal liver, making nodules within your liver, obscuring blood flow and that sort of thing. And we can determine this with this fibroscan, which is the machine that determines this elastography. It takes a thump, some form of energy on the liver, and it will track how quickly this wave of energy moves through the liver from one point to another. So if you think of the liver somewhat like a wedge of Jell-O, if you thump it, you may not feel the thump on the far side of that dome of Jell-O. And your liver, quite frankly, is like Jell-O. You can punch it, it depresses, you take your finger off, it re-expands. You thump it, and when it's soft, that wave of energy doesn't move very fast. When it's stiff with scar tissue, it moves much faster. So a fast, high number compatible with advanced fibrosis in our fibroscan. Put that with a result from your FIB4. When the two line up, we don't need to do nearly as many liver biopsies. Well, we've talked about how we assess the liver in both health and disease, and how we use imaging to determine whether or not a chronically diseased liver has developed scar tissue. And as you know, as this scar tissue moves from one phase to another, we ultimately have an end-stage liver with cirrhosis, which means advanced scarring with nodular deformation and regeneration in the liver. And we've replaced much of this wonderful organ with scar tissue that does nothing for us. Many of the 500 tasks are not being done well, and we begin to suffer from it. Our blood flow is interrupted, and we begin to accumulate fluid where it shouldn't be. So there are several things we do. If you're a provider seeing a person who may have liver disease, you look at them, see what you can determine just by their appearance. You talk to them, ask how they feel, and you do a physical examination. And just that observation can tell you a lot. Looking at this individual who's pictured here on the right, this is an individual who has very advanced liver disease, what we would call end-stage cirrhosis, advanced cirrhosis with end-stage liver disease. His skin is abnormal. It has a yellow hue, that's jaundice. If we could see his eyes, they would be yellow. That is called scleral icterus. Look at his skin, it's splotchy. Well, some of that is just from bruises because he's losing his platelets in this setting of cirrhosis, with a lot of blood being forced back to the spleen and his platelet count going down. But some of these splotches are actually abnormal blood vessels caused by end-stage liver disease. On his chest, up toward his neck, those are what we call spider angiomas. The spider angiomas are a tiny blood vessel that is coming to the skin that stops short of the skin, but you can actually see the blood pulsate. If you look carefully, you can see a tiny pulse. If you gently put your finger on that, you will stop the pulsation, and that splotchy redness goes away because that splotchy redness is like a spider web of tiny blood vessels. These spider angiomata are present in advanced liver disease. If you were to see the palms of his hands, they would be intensely red, what we call palmar erythema. If you were to see his legs, they may be swollen. You see that his abdomen is protuberant. It's filling with fluid. That's ascites. Those breasts of his, those are real breasts, unfortunately for him, and they'd hurt. He's growing true breast tissue. Gynecomastia is the term for that. And that's because his testosterone is gone, because his testes have atrophied, and the estrogen is taking over because it's not being metabolized by the liver. There are many, many things that happen. These are just a few of the physical findings. And then the things we learn by talking to the patient would be that they're tired, they can't think, they may be getting confused, their motor skills are going away. And if you have them stick their arms out, cock their wrist back, and try to hold it, their fingers will start flapping. That's part of the neurologic deterioration that goes along with end-stage liver disease. That process is called asterixis. Just a few of the many findings we see in advanced liver disease.
Dr. Box, there's a couple questions.
Yes.
My first one, how do oncologists manage things like chemo radiation to ensure liver damage doesn't occur?
I'm sorry, I didn't hear that well. Would you repeat it again?
How do oncologists manage things like chemo or radiation to ensure liver damage doesn't occur?
Oncologist and I'm sorry, I'm just not understanding the question, I guess. Would you say it again?
Yeah. How do oncologists manage things like chemo or radiation to ensure liver damage doesn't occur?
Oh, thank you. Okay, I'm sorry. I have a bit of a hearing loss, so I apologize. So for things such as radiation, which can definitely injure any part of the body, including the liver, there are some things that cannot be prevented, but radiation is focused as much as possible. And when feasible, parts of the body, including the liver, that can be shielded are shielded. Unfortunately, if you have radiation to a thing in the liver, such as cancer, there's going to be some injury. And actually, people with very advanced liver disease, even those with cancer, frequently cannot tolerate radiation. However, we are getting better with radiation and really focusing the impact of it right where it belongs. So we're getting better technically with radiation. Sometimes, unfortunately, radiation does harm the liver. And when it's critically diseased already, that harm may be fatal. Now, as far as chemotherapy and immunotherapy, again, these can be toxic therapies. And there are some therapies that have known adverse effects on the liver. And in some instances, we just have to deal with the consequences of the therapy because the therapy is more important than the harm to the liver, which in a healthy liver usually can be resolved during periods between those therapeutic episodes or after a single episode of therapy that may have short-term toxicity. Unfortunately, there are some immunotherapies that turn on an autoimmune injury to the liver for which that medication would have to be withdrawn.
And then the other question was for the slide on testing. It says, does the PET scan show any abnormality to the liver? And why is it so difficult to detect bile duct, pancreatic, and liver?
So the CT scan is very good at showing abnormal changes in the liver. Sometimes the change can only be perceived as a change and we don't know what caused it. That's one of the occasions for a liver biopsy. Some changes are too small to be identified, and some changes are seen only with contrast. That's why with a CT scan and or with the MR scan, contrast is given. Both, there'll be a scan of the liver without contrast, and the dye is injected, and we see where the dye goes that might identify something that wasn't visible with the non-contrasted study. And so we're trying to enhance the sensitivity of CTs as well as MRIs, but some tumors are just so diffusely infiltrating the organ itself that we just can't discriminate it. But we're getting better and better with that. But that's not to say that it's a perfect system and we find everything every time. The pancreas and some other organs are much more difficult to examine, for instance, than the kidneys and the liver. And we do miss small tumors in the pancreas often and have to come back later as things don't resolve. And we finally find it as it gets bigger and bigger. Any other questions?
Yes, there's one more. What can you do to decrease fatty tissue in the liver?
Okay, so I am sure most of you know that the most common injury to the liver in our country, and quite frankly, in most of the world today, comes from fat in the liver. And fat accumulates in the liver under two circumstances. Actually, the first injury to the liver in alcohol-related liver injury is fatty liver. And then as we hurt our liver with ingesting excessive amounts of carbohydrates, and particularly carbohydrates such as fructose, but including glucose and sucrose as well, or fats of all kinds, but particularly trans fats, liver will either turn on a system perversely that makes more fat because of the impact of those toxins, and eventually fat is in excess. The way to remove fat that is in excess is to remove the toxin, which if it's alcohol or too much food or too much highly processed food, is to make dietary changes. We know that in situations of excessive fat in the liver from obesity are that associated with type 2 diabetes mellitus, that weight loss is key to mobilizing that fat. Now, with the use of the drugs now commonplace for weight loss, like the GLP-1 agonists of all kinds, with the weight loss that occurs with that, we are mobilizing fat. The body is made, quite frankly, assuming that there's going to be protracted periods between ingestion of nutrients instead of eating 3, 4, 5 meals a day or full-time grazing as some of us do. And so the body is made to store excess calories in the form of fat. So weight loss is critical to mobilizing most fat. There are some genetic and metabolic factors that cannot be overcome with weight loss, but the vast majority of situations in our country where people are suffering from steatotic or fatty liver disease will be improved with weight loss, regardless of how that weight loss comes about, whether it's just with caloric intake reduction, the use of medications, or bariatric surgery.
There's a follow-up question to that. Are there any benefits or harm to eating chicken liver or any animal liver?
So the benefits of eating a liver would be derived by what's in the liver, quite frankly. There's nothing magic about eating liver. There is a lot of iron in liver. There's copper in liver. And so those would be sort of the nutrients that may be improved if you were to eat liver. There's also a lot of protein in liver, and there is some fat, and all of those nutrients can be broken down. But quite frankly, there's nothing in liver per se that's going to be any better than just eating a well-rounded diet. So the liver has over 100 disorders, and I think we've actually already talked about bullet point number 1. The most common cause of liver disease in our country today is excessive intake of alcohol and overnutrition. We truly have a problem with food addiction in our country. Also, it is no surprise to most of you, I'm sure, that viral infections are another leading cause of chronic liver disease. The most common chronic viral infection in our country is hepatitis C, but in other countries worldwide, it would be hepatitis B. But those two make up the third most common drivers for liver transplant in our country and across the world. Hepatitis D is the third chronic virus that infects the liver. Fortunately, we don't have a huge problem with it in this country, but we're seeing it more and more in patients who also have hepatitis B. Viral infection, hepatitis A, fortunately, is a short-term disease. It rarely causes a fulminant situation where the liver gets so sick that it quickly dies. That's called fulminant hepatic failure. That's from hepatitis A. Hepatitis A does not become chronic. Autoimmune hepatitis is exactly what it says. The body's own immune system turns on itself and attacks the liver cells. There are actually 2 autoimmune diseases of the bile duct system: primary biliary cholangitis and primary sclerosing cholangitis. They both attack the biliary tree, but in different ways. Hepatocellular cancer is one of many tumors that affect the liver. Many benign tumors affect the liver. Adenomas affect the liver. Adenomas may grow so big they have to be removed, though. But certainly the major tumor that we are worried about is the one that is the feature of this webinar series, and that is hepatocellular carcinoma. And in the United States, the most likely situation is the presence of cirrhosis from which that cancer has come, even though there are primary hepatocellular cancers in perfectly healthy livers, but that's very unusual. Storage diseases of iron and copper can affect adults, and then in children it would be glycogen storage disease. In pediatrics, the most common reason that young children need a liver transplant would be congenital failure to develop the bile duct system called biliary atresia. There are also diseases that affect bile in children called primary familial intrahepatic cholestasis. And finally, vascular tumors, including hemangiomas, which are benign, but malignant sarcomas are other vascular disorders of the liver. As I've said, a chronically infected liver, or chronically diseased, I should say, liver progresses to cirrhosis. Here you see the artist's rendition of going from the first injury that becomes chronic. And almost all of the chronic diseases of the liver start out almost without symptoms. People rarely are sick enough with hepatitis C to go see a doctor when they first get it. People don't know they have autoimmune hepatitis or primary biliary cholangitis. But as this chronic inflammation that arises in response to the ongoing injury keeps going, we've already discussed how that lays down scar tissue, which gets thicker, denser, more serious, replacing liver tissue, replacing liver function with scar tissue, at which point cirrhosis, which is advanced scarring, develops. And annually, once cirrhosis, which actually starts asymptomatically in the vast majority of people, on an annual basis, 3 to 6% will develop one of the three major decompensating events, which is ascites, fluid in the belly, confusion, somnolence, that's encephalopathy, or bleeding varices. Those are what's called decompensating events, and once one of those occurs, the clock is ticking. The likelihood of dying within the next year after a decompensating event is 15 to 20%. The likelihood of dying in the next year, once you've had two decompensating events, is about 50%. Regardless of whether or not there's decompensation, the risk of hepatocellular cancer goes up at the rate of 1 to 5% per year once you have cirrhosis. So in this situation, the reason that we have cirrhosis in most of the individuals in the United States arises as a result of fatty liver disease, alcoholic liver disease, or chronic hepatitis C going to cirrhosis. Just so you will know what a normal human liver looks like, this is obviously a liver that's about to be put into a lucky recipient of this gift of life. This is the right lobe up above, the left lobe below, and this will be perfused with some cooling solution before it's put into the individual whose liver is currently being taken out in this operating room image. So progressive liver fibrosis is shown from you here in this artist's rendition. These are the three most common diseases that lead to liver failure in our country. And we've discussed non-alcoholic fatty liver disease, alcoholic liver disease, and hepatitis C. And they all start out with a basic injury, typically asymptomatic, leading to fibrosis, cirrhosis, and ultimately, in many people who have their disease for a long time, hepatocellular cancer. This is what a severely cirrhotic liver looks like. The right lobe is no longer recognizable. The left lobe looks funky. There are a lot of nodules on this, both small and large. And you would think, how could this not be cancerous? But it is not cancer. But This one, as you see, with the cancer coming to the surface, it typically starts inside the liver. This is a more shrunken liver, a more deformed liver than the one we just saw. And these yellow nodules on the outside are the cancer coming to the surface. So this brings us to the end of what I have prepared. I thank you all for your attention today. It's been a pleasure talking to you about the liver in health and as it diseases, as it gets sicker. And I hope you stick with this program and learn a whole lot more about hepatocellular cancer. Y'all take care.